In Chapter 5, we're going to cover community organizing and building and health promotion programming. Here are the chapter objectives for Chapter 5. To deal with the health issues that face many communities, community and public health professionals must possess specific knowledge and skills. They need to be able to identify problems, develop a plan to attack each problem, gather the resources necessary to carry out that plan, implement that plan, and then evaluate the results to determine the degree of progress that has been achieved. In this chapter, we present two other important tools that each successful community and public health worker must master. This includes the skills to organize and build a community and to plan a health promotion program. For community organizing and building and health promotion programming, efforts to be successful must change their behavior. The ultimate goal of these programs and plans is to change some type of behavior, whether that be increasing healthy behaviors or stopping unhealthy behaviors. To be able to better understand the behavior change associated with community organizing and building and health promotion programming, we need to introduce two important concepts. The first one is evidence-based practice, and the second is the socio-ecological approach. Evidence is the body of data that can be used to make decisions. When the community and public health workers systematically find, appraise, and use evidence as the basis for decision-making related to community organizing and building and health promotion programming, it is referred to as evidence-based practice. Evidence comes in many different forms, ranging from objective evidence derived from science to subjective evidence that can come from personal experiences and observations. Because objective evidence comes from the scientific process, it is usually seen as a higher quality of evidence. Community and public health workers should strive to use the best evidence possible, but also understand that scientific evidence associated with some health problems may not be available or even exist, and thus they're faced with using the best available evidence. The socio-ecological approach to behavior change. The underlying foundation of this approach, sometimes called the ecological perspective, is that the behavior has multiple levels of influence. That is, individuals influence and are influenced by their families, social networks, the organizations in which they participate, such as workplaces, schools, religious organizations, the communities of which they are a part, and the society in which they live. So these things all interact with each other on all levels. In other words, the health behavior of individuals is shaped in part by the social context in which they live. Scholars who study and write about the level of influence have used the various labels to describe them. For many years, the commonly used labels for the levels included intrapersonal, interpersonal, institutional or organizational, community, and public policy. Most recently, two additional levels, physical environment and culture, have been added. This is the old model of the socio-ecological model. You can see that it starts with the individual. We start with personal beliefs, knowledge, attitudes, and skills. And this affects your interpersonal relationships with families, friends, and social networks. And then you have the organizational, again, which is where you work, where you go to school, businesses around you. And then the community. The community includes the design of the community, the types of access you have, right, to medical professionals, facilities, etc. And then lastly, we have public policy. This includes national and provincial, local laws, and policy. And again, these all interact with each other. Community and public health problems can range from small and simple to large and complex. Small, simple problems that are local and involve few people can often be solved with the effort of a small group and a minimal amount of organization. However, large, complex problems that involve whole communities require significant skills and resources for their solution. For these larger problems, a considerable effort must be expended to organize the citizens of the community to work together and implement a lasting solution to their problem. For example, A trained smoking cessation facilitator could help a single person or a small group of people stop smoking. But to reduce the smoking rates of the community collaboration is needed. So community organizing is a process through which communities are helped to identify their common problems or goals, mobilize their resources, right? So find out what they have access to and how they can use it to help them, and develop and implement strategies for reaching the goals they have collectively set. So it's not an exact science, but rather an art of consensus building. So it's an art of people coming together and deciding what's most important to tackle, and then working on that goal together. Now we're going to define some key terms for this chapter. The first one is community capacity. Community capacity is defined as community characteristics that affect its ability to identify, mobilize, and address problems. The community capacity refers to their ability to address issues. Empowerment is defined as social action process for people to gain mastery over their lives and the lives of their community. Grassroots participation is defined as bottom-up efforts of people taking collective actions on their own behalf, and they involve the use of a sophisticated blend of confrontation and cooperation in order to achieve their ends. So you can think of this as the volunteer organizations we discussed earlier in this class. So they started because someone found a need and tried to fill it, and then it became bigger as time went on. Macro practice is defined as the methods of professional change that deal with the issues beyond the individual, family, and small group level. Participation and relevance is defined as community organizing should start where the people are and engage community members as equals. Social capita is defined as the processes and conditions among people and organizations that lead to their accomplishing a goal of mutual social benefit, usually characterized by interrelated constructs of trust, cooperation, civic engagement, and reciprocity, reinforced by networking. In recent years, the need to organize communities seems to have increased. Advances in electronics and communications, household upgrades, and increased mobility have resulted in a loss of a sense of community. Individuals are much more independent than ever before. The days when people knew everyone on their block are past. Today, it's not uncommon for people to never meet their neighbors. In other cases, people see or talk to their neighbors only a few times each year. Because of these changes in community social structure, it now takes specific skills to organize a community to act together for the collective good. For community organizing, there are a few assumptions that are made. The first one is that communities of people can develop the capacity to deal with their own problems. So this means we're assuming that the community has the ability to solve the issue. Okay. Second, we assume that people want to change and can change. Now this is one of the biggest assumptions of anything in a health-related field, right? That people want to change and can change. Another assumption is that people should participate in making, adjusting, or controlling the major changes taking place within their communities. In essence, we're assuming that people should take a part in solving the problem. Changes in the community living that are self-imposed or self-developed have a meaning and permanence that imposed changes do not have. A holistic approach can successfully address problems with which a fragmented approach cannot cope. Democracy requires cooperative participation and action in the affairs of the community, and people must learn the skills to make this possible. Frequently, communities of people need help in organizing to deal with their needs, just as many individuals require help in coping with their individual problems. So with all these assumptions, these are the things that we're assuming before we go help a community, right? That they need the help, they want to change, they have the ability to do so as long as they have a little guidance. So when it comes to community organizing, there is no single preferred method. Early approaches to community organizing used by social workers emphasize the use of consensus and cooperation to deal with community problems. However, Rothman created a typology of three primary methods of community organization: local development, social planning, and social action. More recently, these strategies have been renamed planning and policy practice, community capacity development, and social advocacy. At the heart of the planning and policy strategy are data. By using data, community and public health workers generate persuasive rationales that lead toward proposing and enacting particular solutions. And all three of these stages incorporate fundamental principles. First, that you should start where the people are. If you enter a town to help out and see that they don't have very many resources or they're very hesitant to change, you have to start there. You have to acknowledge that and start. If you start educating people that don't want to be educated, you're not going to be successful. The community capacity development strategy is based on empowering those impacted by a problem with knowledge and skills to understand the problem and then work cooperatively together to deal with the problem. Group consensus and social solidarity are important components of this strategy. The third strategy, social advocacy, is used to address a problem through the application of pressure, including confrontation, on those who have created the problem or stand as a barrier to a solution to the problem. This strategy often creates conflict. So one method of this would be, we could talk about big tobacco, right? So smoking is a common health issue. We're aware that it causes lots of health hazards. So being an advocate, we would advocate for smoking cessation programs, and we would aim and target it at smokers, right? And especially the companies that produce cigarettes. Although each of these strategies has unique components, each strategy can be combined with the other to deal with the community problem. In fact, Rothman has offered a 3x3 matrix to help explain these combinations. And you can see this in the figure here. Whatever strategy is used, they all revolve around a common theme. The work and resources of many have a much better chance of solving a problem than the work and resources of a few. Next part of this chapter is the process of community organizing and building. The process of community organizing and building begins when someone recognizes that a problem exists in a community and decides to do something about it. This person is referred to as the initial organizer. This individual may not be the primary organizer throughout the community building process. He or she is the one who gets things started. Doesn't mean they'll be in charge the rest of the time. For the purpose of this discussion, let us assume the problem is violence. People in most communities would like to have a violence-free community, but it would be most unusual to live in a community that was without at least some level of violence. How much violence is too much? What's the tipping point? At what point is the community willing to organize to deal with the problem? In a small town community, an acceptable level of violence would be very low, while in a large city, an acceptable level would be much higher. The people or organizers who first recognize a problem in the community and decide to act can be members of the community or individuals from outside the community. If those who initiate community organization are members of the community, then the movement is referred to as being grassroots, citizen-initiated, or organized from the bottom up. In grassroots organizing, community groups are built from scratch, and leadership is developed where none existed before. Community members who might recognize that violence is a problem could include teachers, police officers, or other concerned citizens. When individuals from outside the community initiate community organization, it's referred to as top-down organization. Individuals from outside the community who might initiate organization could include a judge who presides over cases involving violence, a state social worker who handles cases of family violence, or a politically active group that is against violent behavior wherever it happens. In some cases, the person who recognizes the community problem is not a community member. Great care must be taken when notifying those in the community that a problem exists. It is very difficult for someone from outside the community coming in and telling the community members that they have problems or issues that have to be dealt with and they need to organize to take care of them. The next step is to organize the people. Obtaining the support of community members to deal with the problem is the next step in the process. It is best to begin by organizing those who are already interested in seeing that the problem is solved. This core group of community members is referred to as the executive participants. And they will become the backbone of the workforce and will end up doing the majority of the work. For our example of community violence, the core group could include law enforcement personnel, former victims of violence and their families, parent-teacher organizations, and public health officials. It is also important to recruit people from the subpopulation who are most directly affected by the problem. For example, if most of the violence in a community is directed towards teenagers, teenagers need to be included in the core group. From the core group, a leader or coordinator must be identified. If at all possible, the leader should be someone with leadership skills. The leader should be someone with leadership skills, good knowledge of the concern and the community, and most of all, someone that is from inside the community. One of the early tasks of the leader will be to help build group cohesion. Although the formation of the core group is essential, this group is usually not large enough to do the work itself. Therefore, one of their core tasks is to recruit people. And this could happen via networking processes, such as using community centers, schools, or religious organizations. By broadening the amount of people in the group, the core group can spread out the workload and generate additional resources to deal with the problem. However, recruiting can often be difficult. Over the last 30 years, the number of people in many communities interested in volunteering their time has decreased. Today, if you ask someone to volunteer, you may hear the reply, "I'm already too busy." There are two primary reasons for this response. First, there are many families in which both husband and wife work outside the home. And second, there are more single-parent households. Therefore, when organizers are expanding their constituencies, they should be sure to identify people who are affected by the problem, provide perks or otherwise reward volunteers, keep volunteer time short, and match volunteer assignments with the abilities and expertise of the volunteers. Lastly, you should consider providing appropriate training to make sure all the volunteers are comfortable with their tasks. For example, if the organizer needs someone to talk with law enforcement groups, it would be a good idea to select the help of someone who feels comfortable along law enforcement officers. When the core group has been expanded to include these other volunteers, the larger group is sometimes referred to as a task force. A task force has been defined as a self-contained group of doers that is not ongoing. It is convened for a narrow purpose over a defined time frame at the request of another body or committee. There may even be an occasion where the coalition is formed. A coalition is a formal alliance of organizations that come together to work for a common goal, often to compensate for deficits in power, resources, and expertise. A larger group with more resources, people, and energy has a greater chance of solving the community problem than a smaller, less powerful group. Building and maintaining effective coalitions have increasingly been recognized as vital components of much effective community organizing and community building. Community building is an orientation to practice focused on community rather than a strategic framework or approach and on building capacities, not fixing problems. Thus, one of the major differences between community organizing and the newer idea of community building is the type of assessment that is used to determine where to focus the community's efforts. In the community organizing approach, the assessment is focused on the needs of the community, while in community building, the assessment focuses on the assets and capabilities of the community. It is assumed that a clearer picture of the community will be revealed and a stronger base will be developed for change if the assessment includes the identification of both needs and assets and capabilities. and it involves those who live in the community. It's from these capacities and assets that communities are built. To determine the needs and assets/capabilities of a community, an assessment must be completed. There are two reasons for completing an effective and comprehensive assessment. Information is needed for change, and it is also needed for empowerment. This could include a traditional needs assessment and/or a newer technique called mapping community capacity. A needs assessment is a process by which data about the issue of concern are collected and analyzed. From the analyzed data, concerns or problems emerge and are prioritized so that strategies can be created to tackle them. Mapping community capacity, on the other hand, is a process of identifying community assets, not concerns or problems. It is a process by which organizers literally use a map to identify the different assets of a community. So this could include doctor's offices, recreational facilities, dentists, right? It could be whatever your topic you're discussing. Some people have categorized assets and capacities into 3 different groups based on their availability to the community, and they refer to them as building blocks. Primary building blocks are the most accessible assets and capacities. They are located in the neighborhood and are controlled by those who live in the neighborhood. Primary building blocks can be organized into the assets and capacities of individuals, for example, skills, talents, and incomes, and those of organizations or associations, like faith-based or citizen organizations. The next most accessible building blocks are secondary building blocks. These are assets located in the neighborhood but largely controlled by people outside, such as social service agencies, schools, hospitals, and housing structures. The least accessible assets are referred to as potential building blocks. Potential building blocks are resources originating outside the neighborhood and controlled by people outside, such as welfare expenditures and public information. By knowing the needs, assets, and capacities of the community, organizers can work to identify the true concerns or problems of the community and use the assets as a foundation for dealing with concerns or problems. An analysis of the community assessment data should result in the identification of the problems to be addressed. However, more often than not, the resources needed to solve all identified problems are not available. It might cost too much, or there just might not be enough manpower. Therefore, the problems that have been identified must be prioritized. The prioritization is best achieved through general agreement or consensus of those who have been organized so that ownership can take hold. It is critical that all of those working with the process feel that they own the problem and want to see it solved. Without this sense of ownership, they will be unwilling to give their time and energy to solve it. Miller has identified 5 criteria that community organizers need to consider when selecting a priority issue or problem. First, the problem must be winnable. It must be something you are able to achieve. It must be simple and specific. It must unite members of an organizing group. It should affect many people, and it should be part of a larger plan. Once the problems have been prioritized, goals, or the hoped-for results, need to be identified and written to serve as guides for problem solving. The practice of consensus building should again be employed during the setting of goals. These goals, which will become the foundation for all of the work that follows, can be thought of as the hoped-for end result. In other words, once community action has started and is taking place, what will have changed? In the community where violence is a problem, the goal may be to reduce the number of violent crimes or eliminate them altogether. Sometimes, at this point in the process, some members of the larger group drop out because they do not see their priorities or goals included on the consensus lists. Unable to feel ownership, they are unwilling to expend their resources on this process. Because there is strength in numbers, effort should be made to keep them in. And one strategy for doing so is to keep the goal list as long as possible. There are alternate solutions for every community problem. The group should examine the alternatives in terms of probable outcomes, acceptability to the community, probable long and short-term effects, and finally the cost of resources to solve the problem. Here we have some intervention strategies and example activities, and this will be pretty useful later on. So the first one is health communication strategies. This includes mass media, social media, billboards, flyers, direct mail, etc. Second is health education strategies. This could be lectures, discussions, group works, or online trainings, laboratory exercises, etc. Third, we have health policy and enforcement strategies. And this includes executive orders, laws, ordinances, policies, etc. Fourth, we have environmental change strategies. And these are designed to change the structure of services, systems of care, or the built environment to improve health promotion services. And this includes seat belts, airbags in cars, speed bumps in parking lots, etc. Fifth, we have health-related community services. The use of health risk appraisals, clinical screenings for health problems, and immunization clinics are good examples. Then on row 6, we have some other strategies such as behavior modification, so trying to get people to stop doing something or start doing something, community advocacy, organizational culture activities, incentives, social interventions, and technology-delivered activities. Now again, these are a list of strategies and some examples. The last 4 steps in this generalized approach to organizing and building a community include implementing the intervention strategy and the activities that were selected. Finally, you should evaluate the outcomes of plans of action, and maintain the outcomes over time, and if necessary, go back to the previous step in the process, or loop back, to modify or restructure the work plan to organize the community. So implementation of the strategy includes identifying and collecting the necessary resources for implementation and creating the appropriate timeline for implementation. Often the resources can be found within a community, and thus horizontal relationships, the interaction of local units with one another, are needed. Other times the resources must be obtained from units located outside of the community. An example of this latter relationship is the interaction between a local nonprofit organization and a state agency with which it has a contact. Evaluation of the process often involves comparing the long-term health and social outcomes of the process to the goals that were set in an earlier step. Some scholars have indicated that such traditional evaluations of community organizing efforts are not easy to carry out and have limitations. There are times when evaluations are not well planned or funded. As such, they may fail to capture the shorter-term, system-level effects with which the community is heavily concerned. Maintaining or sustaining the outcomes may be one of the most difficult steps in the entire process. It is at this point that organizers need to seriously consider the need for a long-term capacity for problem solving. Finally, through the steps of implementation, evaluation, and maintenance of the outcomes, organizers may see the need to loop back to a previous step in the process and to rethink or rework before proceeding onward in their plan. Health education and health promotion are terms that are sometimes used interchangeably. This is incorrect because health education is only a part of health promotion. The Joint Committee on Health Education and Promotion defined the process of health education as any combination of planned learning experiences using evidence-based practices or sound theories that provide the opportunity to acquire knowledge, attitudes, and skills needed to adopt and maintain health behaviors. The committee defined health promotion as any planned combination of educational, political, environmental, regulatory, or organizational mechanism that supports actions and conditions of living conducive to the health of individuals, groups, and communities. From these definitions, it's obvious that the terms are not the same and that health promotion is much more encompassing than health education. Program planning may or may not be associated with community organizing or building. but it is the process by which an intervention is planned. This is the relationship of health education and health promotion. In the widest blue circle, we have all of health promotion. And again, it serves all of these purposes: organizational, social, economic, political, policy, and regulatory. And then in the very middle, we see that health education is only a section of health promotion. Creating a health promotion program involves a series of steps, the success of which depends on many factors. For example, getting assistance from health professionals. Experienced planners use models to guide their work. This is useful because you don't have to reinvent the wheel with your plan, right? You can use a previously founded model and follow their guidelines. One example is Precede Proceed. There's another one, Mobilizing Action Through Planning and Partnerships, and this is called MAP, Intervention Mapping, and CDC Synergy. But before this process begins, it's important to understand and engage the priority population. And again, the priority population is those whom the program is intended to serve. When assessing the needs of the priority population, you need to determine the purpose and scope of the needs assessment. We need to gather data, analyze the data, identify risk factors that are linked to the health problem, identify the program focus, and validate the prioritized need. Here's a generalized model of pre-planning for a program. Again, you need to assess needs, collect and analyze data to determine the health needs of a population, and set priorities. You need to set goals of what will be accomplished, develop the intervention, implement the intervention, and then evaluate the results. So the first step is the needs assessment. Again, needs assessment is the process of identifying, analyzing, and prioritizing the needs of a priority population. So what is the goal of the needs assessment? What does the planning committee hope to gain from the needs assessment? How extensive will the assessment be? And what kind of resources will be available to conduct the assessment? Once these are all answered, the planners are ready to begin gathering data. Gathering the data will help identify the true needs of the priority population. Such data are categorized into two groups, primary and secondary. Primary data are those that are collected specifically for use in this process. An example is having the population complete a needs assessment questionnaire about their health behavior. This could be a survey on paper, a face-to-face survey, or telephone interview, etc. Secondary data are data that have already been collected for some other purpose. So these are big databases that we have access to and can use for research. And using both types of data usually presents the clearest picture of the priority population's needs. Setting appropriate goals and objectives. This is the foundation of the program. You need to determine what you want to achieve and be very specific. Step 3 is to analyze the data. You need to collect the data that was collected can be analyzed in one of two ways, either formally or informally. Formal analysis consists of some type of statistical analysis, assuming that the appropriate statistical criteria have been met to collect the data. However, a more common means of analysis is an informal technique referred to as eyeballing the data. The final part of the needs assessment process is prioritizing the list of problems. And we do this because although all needs are important, there's rarely enough resources, people, manpower, money, or time to deal with all of the problems identified. So we need to focus on the importance of the need, how changeable it is, and whether we have the resources to address that specific issue. Step 4 is to identify risk factors. What genetic, behavioral, and environmental risk factors are associated with the health problem? For example, higher than expected obesity and smoking behavior may be present in the priority population in addition to a community that lacks recreational facilities and areas for exercise. Once these risk factors are identified, they also need to be prioritized using the same 3 criteria noted in Step 3. In this step of the process, planners need to identify and prioritize the risk factors. Step 5. Identifying the program focus. With risk factors identified and prioritized, planners need to identify those predisposing, enabling, and reinforcing factors that seem to have a direct impact on the targeted risk factors. Those in the priority population may not have the knowledge and skills to begin an exercise program. These are the predisposing factors. Have access to recreational facilities, the enabling factors, or have people around them who value the benefits of exercise, the reinforcing factors. The 6th step is validating the prioritized need. The final step in this process is to double check or to confirm that the identified need and resulting program focus indeed need to be addressed in the priority population. Now you should be able to address these questions or answer them. Who is the priority population? What are their needs? Which subgroups in the population have the greatest need? Where are they located geographically? What is currently being done to work on this problem? How well have the identified needs been addressed in the past? What is the capacity of the community to deal with the problem? What are the assets in the community on which a program can be built? The words goals and objectives are often used interchangeably, but there is a really significant difference between the two. A goal is a future event which the committed endeavor is directed. Objectives are the steps taken in pursuit of the goal. In comparison to objectives, goals are expectations that provide overall direction for the program, are more general in nature, and do not have a specific deadline. They usually take longer to complete and are often not measured in exact terms. Goals are easy to write and include 2 basic components: who will be affected and what will change because of the program. Here are some examples of program goals. To help employees learn how to manage their stress. To help reduce the number of teenage pregnancies in the community. And to help cardiac patients and their families deal with the lifestyle changes that occur after a heart attack. Again, objectives are more precise than goals. They are often composed of who, what, when, and how much. Here are some examples of objectives and goals. Feel free to pause here and read over this chart. Here's another example of a goal and objective from Healthy People 2020. The goal is increase the quality, availability, and effectiveness of educational and community-based programs designed to prevent disease and injury, improve health, and enhance quality of life. You can see that there is nothing to be measured here. Right? It's vague, it's forward-thinking. The objective is increase the number, so we already have something measurable, the number of community-based organizations providing population-based primary prevention services in the following areas. The next step in program planning is to design activities that will help the population meet the objectives and in the process achieve the program goals. These activities are collectively referred to as an intervention. Although no minimum number has been established, it has been shown that multiple activities are often more effective than a single activity. For example, if the planners wanted to change the attitudes of community members towards a new landfill, they would have a greater chance of doing so by distributing pamphlets door to door, writing articles for the local newspaper, and speaking to local service groups. In other words, the size and amount of intervention are important to health promotion programming. Here are some more intervention considerations. The 2 terms that relate to the size and amount of an intervention are multiplicity and dose. Multiplicity refers to the number of components or activities that make up the intervention, while the dose refers to the number of program units delivered. Thus, if an intervention has two activities, for example, an educational workshop and a public service announcement, they define multiplicity while the number of times of each activity presented defines the dose. So there's two activities, the workshop and the public service announcement. But if they were to present these things 6 times, the dose would be 6. Best practices refers to the recommendations for an intervention based on critical review of multiple research and evaluation studies that substantiate the efficacy of the intervention in populations and circumstances in which the studies were done. If it's not its effectiveness in other populations and situations where it might be implemented. When best practice recommendations are not available for use, planners need to look for information on best experiences. Best experience intervention strategies are those of prior or existing programs that have not gone through the critical research and evaluation studies and thus fall short of best practice criteria, but nonetheless show promise in being effective. If neither best practices nor best experiences are available to planners, the third source of guidance for selecting an intervention strategy is using best processes. Best processes intervention strategies are original interventions that planners create based on their knowledge and skills of good planning. They include the involvement of those in the priority population and the theories of models used to change behaviors. So the best thing we can use is best practices, which have been evaluated and researched. Best experiences have some substantial evidence, but not nearly as much as best practices. And lastly, we have best processes, which are just pulling from previous interventions. To ensure a smooth flowing intervention or implementation, it is wise to use a pilot test, at least once, sometimes more. A pilot test is a trial run. It is when the intervention is presented to just a few people who are either from the intended priority population or from a similar population. For example, if the intervention is being developed for 5th graders in a particular school, it might be pilot tested on 5th graders in a similar school. If the program being planned is implemented with a large priority population, and there's a lot at stake with the implementation, it is advisable that the intervention be implemented gradually rather than all at once. One way of doing so is by phasing in the intervention. Phasing in refers to a step-by-step implementation in which the intervention is introduced first to smaller groups instead of the entire population at once. Evaluation is the process in which planners determine the value or worth of the object of interest by comparing it against the standard of acceptability. Common standards of acceptability include, but are not limited to, mandates, such as policies, statutes, and laws, values, norms, comparison groups, and the how much in an objective for the program. Evaluation can be categorized further into summative and formative evaluation. Formative evaluation is done through the planning and implementing process to improve or refine the program. Validating the needs assessment and pilot testing are both forms of formative evaluation. Summative evaluation begins with the development of goals and objectives and is conducted after implementation of the intervention, and this determines the program's effect on the population. Often, the summative evaluation is broken down into 2 categories: impact evaluation and outcome evaluation. The impact evaluation focuses on the immediate observable effects of the program, such as changes in awareness, knowledge, attitudes, skills, environmental surroundings, and behavior of those in the population. Whereas outcome evaluation focuses on the end result of the program and is generally measured by improvements in morbidity, mortality, vital measures of symptoms, signs, or physical indicators. The last steps of evaluation include engaging stakeholders. These individuals must be engaged to ensure that their perspectives are understood and that the evaluation results meet their expectations. If stakeholders are not engaged in evaluation, findings may be ignored, criticized, or resisted. And again, the stakeholders are very important people in the program. Next, you need to describe the program. A clear program description helps to clarify program components and the intended outcomes. Therefore, well-written goals and objectives and a well-conceived intervention are important steps in describing the program. Focus on the evaluation design. This step of the evaluation process includes stating the purpose of the evaluation. For example, improving the quality of programming or assessing its effects, or both, and formulating the questions to be answered by the evaluation. Once those things have been completed, a specific evaluation design, either a qualitative or quantitative one, and the type of data analyses can be determined. Next, you need to gather credible data. Gathering credible data includes deciding what type of data needs to be collected and how to collect it. You need to determine who will collect it, and then pilot test the procedures, and then perform the actual data collection. Once the data are in hand, they must be analyzed and interpreted. This means that the evaluator will compare the collected data against the standards of acceptability to determine the effectiveness and ultimately the value of the program. Lastly, you need to ensure use and share lessons learned. After the data have been analyzed and interpreted, the evaluation report should be written. Decisions must be made regarding who should write the report, who should receive the report, and in what form it should be distributed, and also when it should be distributed. With the findings in hand, it must then be decided how they will be used. When time, resources, and effort are spent on an evaluation, it is important that the results be useful for reaching a constructive end. This is a time when a decision can be made to modify, continue, or discontinue the intervention based on the evaluation data. Here are some discussion questions to wrap up the lecture. How would you explain the difference between health education and health promotion? How can community members work together to solve health problems?